Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation continuing medical education chapter meetings, and in our usual time, Wednesday 9 p.m. And today I am really pleasured and really happy to have two of my great friends and two of great scientists in Egypt as the moderator and the speaker in this session. This session is targeted to cystic kidney disease, and I am really pleased to have Professor Ahmed Al-Qara'i as the moderator of this session. Professor Ahmed is the professor of nephrology and medicine in Alexandria University, and he is the head of nephrology department and nephrology unit in Alexandria University. He is currently the board member of Egyptian Society of Nephrology and Transplantation and the head of genetic working group of APRAN. And he is interested in glomerulonephritis, kidney pathology, and in kidney transplantation. Our speaker today, he is a distinguished one in this field of cystic kidney disease. He is my friend, Professor Hatem Darwish, who is professor of nephrology and medicine in Cairo University, and he gained his experience from France in past training in France regarding polycystic kidney disease. I am expecting a very interesting lecture and hot scientific discussion following the lecture, and great interactions from our moderators and all professors attending this session. Let me start and come to you again with the discussion after the lecture. Professor Ahmed, please.
Thanks, Professor Yasser, for the introduction. Bismillah, alhamdulillah, Rasulullah. It's really a very nice initiative again, and very nice topic, well selected speaker, Professor Hatem Darwish, and the cystic kidney diseases. And the very nice thing is the cystic kidney disease is not the polycystic kidney only, just to have the broader view, to understand that you sometimes might be faced by patient who does not fit classically into the polycystic kidney. You have to look for the differential diagnosis. For our junior colleagues, you have to understand when the simple cyst is important and when it is not important. It's just like your gray hair, and what to do, what's next, how is the differential diagnosis, and what is the approach. Nowadays, we are waiting for, as you know, for the 12-10 to be available in Egypt, and you have to understand when to use and how to use, and what is the TKV, and how you should take the MR studying for this, and what is the high rate of progression that necessitates that you need to use it. What are the side effects? Who is the patient that you would use the drug for, and who is the one that you are not going to use, what to expect as a result, and what to expect as side effects, and much more expected from Professor Hatem Darwish, the real, very gentle, nice, polite, scientific professor of nephrology that we usually and always actually being very much interested in his talks and his scientific approach. But if you, please, Professor Hatem, without further ado, proceed to your presentation, and we will discuss the points and the questions that will be uploaded on the chat by the end of the presentation. Thank you.
Assalamu alaikum. Thank you, Dr. Yasser. Thank you, Dr. Ahmed, for both very nice introduction. And I hope I will meet your expectations, inshallah. And my primary intention in my lecture is just to give you the fast differential diagnosis of this topic. The therapeutic part and the interventions, actually, I didn't intend to make it in this lecture. I will give you just one or two slides in the end of this lecture to give you an idea about the interventions which we intervene with the autosomal dominant especially. but it is not intended to discuss the therapeutic intervention for this disease. It's just to understand the cystic kidney disease as a broad entity, as a very big entity, not only autosomal dominant polycystic kidney disease. This is my primary intention. Bismillah. So this is my agenda, how the cyst is formed in the kidney, the pathophysiology of the cyst, to understand the clinical picture. Then I am going to discuss the classification to give you the spectrum of this disease. Some of it is hereditary, autosomal dominant, recessive, or syndromic, congenital, acquired. And the role of genetic is the last part, when to go for genetic testing. And I will just touch the therapeutic intervention because this lecture is not intended primarily to discuss the therapeutic intervention of these diseases. So, as I told you, the cyst inside the kidney is a very common, and you have to describe it. Where is it? In the cortex, in the medulla, small, large, with atrophy, partial. All of this will put you in a special entity. So to understand how cyst is formed in the kidney, you have to start to understand the epithelial cell. It started from the epithelial cell. The epithelial cell is a very peculiar type of cell. And it has a very special structure, and it has two types of polarity. It has a cytoskeleton, which makes it has a basolateral and apical portion, which is very important and crucial to its function. But we sometimes overlook the cilia inside the epithelial cells, and it is a very important structure of the epithelial cells, which gives the epithelial cell another unique polarity, which we call it planar polarity, not vertical polarity like basolateral and apical. It is a planar polarity. And this cilia controls a lot of molecular functions and cellular differentiation and cell function. And actually, it started from the embryo after fertilization and starting the nephrogenesis, and it controls mesenchymal induction, cell proliferation, and the branching morphogenesis. And if any mutations happens to this cilia, it will lead to tubular geometry problems and planar polarity problems. And this is why this group of diseases, we call it ciliopathy. The polycystic kidney is stemmed from this cilia. All the diseases comes from this cilia. This cilia is a very peculiar structure. It has a cytoskeleton, it has a basal part, and it controls a lot of intracellular function, cell differentiation, cell proliferation, molecular channels, everything comes from this cilia. And almost 70 genes and the proteins has been located to this cilia, and each mutation of which will lead to disturbance of the cilia function and different disease processes with different polycystic syndrome will be developed. And it started from the tubular epithelial cell mutation leads to ectatic changes and the proliferation, and then it separates from the tubules and becomes secretory in spite of absorptive, leads to formation of the cyst. But actually, this is oversimplification of the pathogenesis of the cyst formation, because any abnormality of these genes in the cilia leads to a cascade of secondary events intracellularly. Some increase in the proliferative pattern MAP ERK kinase, which is a mitogenic pathway and mTOR, and we have some other secretory pathways, dislocation of sodium potassium channel from the basal to apical part, a lot of the secondary events. So if we are talking about tolvaptan as a potential treatment of the polycystic kidney disease, it's actually a control, a very tiny part, very tiny part of a very big picture and the story of polycystic kidney. It is only controlling very much. It just delays the progression for a few years. So it is not more than that, because the story is huge and tremendous, and there is a lot of the secondary events. Of course, we cannot control all of this. Vasopressin antagonists like tolvaptan will control only small part of this large pathogenesis of the cyst formation. So we go back to the second part and the classification, and actually this is my primary intention from this lecture, to know that the cyst inside the kidney and polycystic kidney is not a simple entity. It is a very huge differential diagnosis. And if we go to the first entity, which is hereditary cystic kidney diseases, we'll find, of course, the most famous and the most common autosomal dominant polycystic kidney disease. But we have also tuberous sclerosis, von Hippel-Lindau, and we have a new entity. It is not new, but this is the new terminology, autosomal dominant tubulointerstitial kidney disease. And this disease actually causes confusion to the nephrologist for a long time until it is grouped under this title. And I will describe it because it has given different names. You will find different names in the literature: medullary cystic kidney disease, juvenile hyperuricemia, glomerulocystic disease, uromedulline associated. A lot of definitions and terminology given to this entity before it is grouped under this title, autosomal dominant tubulointerstitial kidney disease. Autosomal dominant polycystic kidney disease, of course, all the nephrologists know this because it is very common. It is common. Its prevalence is 1 in 500 to 1,000, so it is very common. And you know that it causes hypertension, lung pain, hematuria, cyst infections, repeated infections, and cerebellar aneurysms, and all of know the clinical picture. And it is caused by polycystin 1 and polycystin 2 proteins, and it's a huge protein. Polycystin 1 is a huge protein, 46 exons, and has a lot of motifs. The protein, to understand its function, it has a different motifs. Its part of the protein has a specific function, and this protein spread goes extra cellular and spans part of the membrane and part intracellular. So it has a lot of function in cell-cell matrix, cell-cell interaction, intracellular function, and it co-localize with polycystin 2. And all of them, both of them, polymerize and co-localize in the cilia, controlling a lot of its function, polycystin 1 and polycystic 2. This is the two major genes. And the diagnosis primarily depends on the ultrasound examination. But you have to understand, this Ravine criteria, which has been developed in 1990s, it depends on the patient genetic background. So if this patient is from a family that it is known with polycystic kidney disease, so we, before the age of the 30, we have just a diagnosis with 2 cysts in 1 kidney or 1 in each kidney. From 30 to 60, we have 2 in each kidney. Above 60, we need 4. This is the most famous. All of us know this primary simplified criteria for diagnosis of autosomal dominant polycystic kidney disease. But we have to know this is actually for the patients with at risk of known family with ADPKD type 1. If non-genotype, we need more stringent criteria. If we used recently modified criteria, we put MRI in the criteria, but of course, ultrasound can detect cyst from 0.5 to 0.6. In magnetic resonance can get cyst from 0.2 to 0.3 millimeters. So it detects more cyst. And actually, this is reflected here. If you have intrafamilial donation, if from family intrafamilial donation inside a polycystic family, this Ravine criteria, ultrasound criteria, is a specific 100%, but sensitivity is less. So if a patient wanted to donate, his brother wanted to donate him, and he is less than 40 years of age, and you did ultrasound and you didn't find a cyst, you cannot exclude still he has a polycystic kidney disease because there is a false negative 2%. At this stage, before the age of the 40, intrafamilial donation to exclude either to do genetics or do MRI to exclude any cyst formation before the age of 40. This is the classic picture in the ultrasound of autosomal dominant polycystic kidney disease. Innumerable different sizes cysts in the ultrasound, of course, in the CT, in the MRI, T1 and T2. But actually, with practice, we discovered that this is not the typical picture in the imaging of the polycystic kidney disease. It is not the only pattern. We have a different pattern. This is why we call it now typical polycystic kidney disease, and it is classified by Mayo Clinic from A to E, A, B, C, D, E, and we have a typical presentation. What is this atypical presentation? Sometimes we are confronted with unilateral polycystic kidney. Sometimes asymmetric, one kidney affected more than the other. We have loop size, more than huge cysts in one kidney and not other cysts. It's a huge, not numerable, few. And maybe mild loop-sided, maybe segmental sparing with different cysts with renal atrophy. All of this picture, imaging picture, is not typical of autosomal dominant polycystic kidney disease. And when we analyze this, we find, of course, a difference. In a cohort of patients of almost 550 patients, we find around 50 patients with this atypical presentation. And they have older age, of course, with more preserved kidney function, and it is unlikely to be linked to BKD1 in BKD2 and no mutation detected in around 80% of atypical presentation. While, as I will illustrate in a minute, in a typical presentation, only 9% is not, we didn't find the mutation. We didn't find in the BKD1 or BKD2. And of course, here, just to understand this abbreviation, the type of mutation depends, will be reflected on the progression of the disease. So if we have protein truncation, the protein is reduced, the major part of the protein is truncated, this will lead to severe phenotype. Is just the insertion deletion, this is milder form. Non-truncated, this is more milder form. BKD2 is a mild form. So it depends on the mutation, and it is now being classified, put in a scoring system of severity of polycystic kidney disease to score this severity, because this will be reflected again on the therapeutic decisions. Mentioned that, just again to highlight that autosomal dominant polycystic kidney disease, in the vast majority of patients, almost 80%, you will find it is linked to BKD1. 14% will be linked to BKD2. Nowadays, there is a lot of other minor genes, and still around 6% you will not find the mutation, and you have to dig again inside the genome to find where is the gene causing this cystic kidney disease. And this will reflected in the patient clinically, not autosomal dominant polycystic kidney disease, all the same. Even within the same family, within the same mutation, we will find that there is discordance in the clinical picture among family members with the same mutation. Why is this? Because there is, as I mentioned, there is some genetic factors. Coexisting disease, they are part of the general population, so they are exposed to maybe secondary glomerulonephritis. A complication which happens by chance to this patient, infections, structure, aneurysms, kidney stones, comorbid conditions, which has been now highlighted the metabolic element in the progression of kidney disease, obesity and the metabolic syndrome, and the nutritional issues in the progression of the kidney disease is being focused on. And of course, some environmental factor, water intake, smoking, exercise, alcohol, caffeine, and the treatment adherence if the patient is going to take tolvaptan, because again, tolvaptan has some complications, and it is difficult because it causes too much polyuria, and some patient does not tolerate this. This part is mimics of the autosomal dominant polycystic kidney disease, which autosomal dominant, which also autosomal dominant, and it gives similar picture, but with more peculiar extrarenal manifestation. One of them is tuberous sclerosis. Tuberous sclerosis is the next to the polycystic 1 gene on the short arm of chromosome 16. And some cases in the literature describe early onset of polycystic kidney disease due to large deletions affecting polycystic 1 and the tuberous sclerosis gene type 2. This has been described in the literature, but actually it is a distinct type with a different protein which controls the proliferation. So it gives a lot of the tuberous fibromas, especially in the brain and the skin. You find here, this is very peculiar, and it is a very common target in the different exams in the MRCP, and anyone wants just to detect to test the knowledge of this. This is very peculiar in the exam. Sub-angle fibroma with tumors in the face, ash-like melanoma, and this is angiomyolipoma in the kidney, and astrocytoma in the brain. This is peculiar to the tuberous sclerosis. And the other mimics of autosomal dominant polycystic kidney disease is von Hippel-Lindau. Von Hippel is an ophthalmologist, a German ophthalmologist, who describes the retinoblastoma component of this disease. Erdős Lindau is a Swedish pathologist who describes the full-blown picture of the von Hippel-Lindau syndrome, and actually is a tumor suppressor genes which controls the proliferation of the cells. When it is mutated, leads to very peculiar. This is a very similar picture to ADPKD, but we find solid masses. Solid masses because it is very important to cause renal cell carcinoma, clear cell type, and retinoblastoma in this von Hippel-Lindau. So if you find similar picture to autosomal dominant polycystic kidney disease, but you find solid masses beside the cysts, you have to think about tuberous sclerosis and von Hippel-Lindau. This is the autosomal dominant part polycystic kidney disease. We have another entity which now called autosomal dominant tubulointerstitial kidney disease. It is different from the first part of the autosomal dominant polycystic kidney only. This particular tubulointerstitial disease is a dominant inheritance, slowly progressive, bland urinary sediment with renal cyst, tubulointerstitial fibrosis, end-stage disease usually later on life. And peculiar to this group is very early onset of gout. even in females, perimenopausal, because this is very, very rare for a perimenopausal woman to have a gout, unless they have severe metabolic disorder. So this is peculiar, very early disease with gout, especially uromodulin. This uromodulin is the most common entity of this group. It represents 60%, followed by mucin-associated 30%, followed by renin and hepatocyte nuclear factor, growth factor. And this is peculiar because it is accompanied with diabetes and pancreatic hypoplasia. This disease is of interest to the adult nephrologist because its presentation is actually in adolescents, young adults, and the middle age. It is if you take a biopsy, it will be interstitial nephritis. It's only interstitial nephritis in a patient with recurrent attacks of severe gout early onset in his life. This is a general theme of this group. And this comes to interest when Mayo Clinic comes to its classification. So you find that there is some atypical presentation, like this case, 41-year-old man with 7 to 10 cysts in the right and the left kidney. By definition of Ravine criteria, this is autosomal dominant polycystic kidney disease. But it is not, because his kidney is small, GFR is not that severely impaired, has a strong history of renal cystic disease reaching indices in his family. لكن الجينيتك ستاديز طلعت انه هو ميوسين associated polycystic kidney disease. فعرفوا they discovered that there is some atypical presentation which is mimic the autosomal dominant polycystic kidney disease, but it is not typical to the presentation. Another case, 29 woman with bilateral renal cyst, more than 10 in each kidney, with height adjusted total kidney volume. We depend on this. This is what has been invented by Mayo Clinic imaging classification of polycystic kidney disease, and we depend on this to justify the patient who is a candidate for 12-10 or not. 186, this is a small kidney. This is enlarged, but it is not huge. The polycystic kidney really reach up to 700, 800 with GFR 70 ml per minute. And her mother also have a cyst, and she was found to have a mutation in hepatocyte nuclear factor gene. Another case with more than 10 cysts in each kidney and a height adjusted total kidney volume to 10. With GFR is 92, and was found a mutation in DNAGP1, a minor gene causing polycystic kidney disease. When I started studying this disease in the 90s, we just say we have polycystic 1, polycystic 2, and we still have some population. Third focus has to be identified. Nowadays, it is being identified. It's being identified. We have minor gene causing similar picture to autosomal dominant polycystic kidney disease with different genes. Another one with uromodulin again. So uromodulin is the most common of this group. And this uromodulin, the other name, the old name of it is TAM horsefall protein. This TAM horsefall protein has a very important function in protection against kidney stone because it decreases physically the crystallization of the urate and calcium crystals, and it has innate immunity. It's important to prevent infections. And control of the sodium-potassium 2 chloride channel, which is the target of the loop diuretics, and control blood pressure. So this uromodulin is very important to the normal function of the kidney. When it is mutated, it leads to this phenotype. In the literature, you find different names to this uromodulin. It is now polycystic kidney disease uromodulin. You will find the medullary cystic kidney disease type 2. You will find familial juvenile hyperuricemic nephropathy, and you find glomerulocystic kidney disease. All of this terminology is polycystic kidney disease uromodulin associated. And of course, when it is mutated, it is kept inside the cell, leading to apoptosis, impaired autophagy, and mitochondrial dysfunction, leading to the peculiar phenotype of interstitial fibrosis and the chronic kidney disease. This is the autosomal dominant part of cystic kidney disease, classic autosomal dominant polycystic kidney disease, and tubulointerstitial part. We have autosomal recessive. Autosomal recessive, is the famous autosomal recessive polycystic kidney disease, and another group, nephronophthisis. Autosomal recessive polycystic kidney disease is rare disease, and you have to think about it as a spectrum between kidney affection and liver affection. Liver affection is an integral component of this disease. And I still remember the first case I saw this entity during my residency, a 16 years old young man, which comes to our department with hematemesis. and we discovered he has portal hypertension and esophageal varices, but accidentally we discovered that his creatinine is around 4, and his kidneys is mildly enlarged with few cysts. At that time, in the 90s, we just called this polycystic kidney disease adult type and infantile or juvenile type. These names, of course, has been obsolete from the literature because we remember known as that autosomal recessive juvenile type has adult onset and the patients can survive. The old concept is this patient is dying during their infancy or early childhood. They don't come to the adult practice. But when I presented this case and we reached this diagnosis, this is autosomal recessive polycystic kidney disease with main branch on the liver, presenting with Caroli syndrome, hepatic fibrosis, with pulmonary hypertension and esophageal varices, with lesser affection on the kidney. These patients survive. So in the infancy, you will find the kidney is a little bit enlarged. In the ultrasound, there is no cyst in the ultrasound because the cyst is small, and actually it's a fusiform dilatation of the distal collecting tubule and collecting tubules, and it's very small cyst. So in the ultrasound, it is only echogenic kidneys. Later on life, it might see some cyst. But during the infancy or childhood, if the kidney is mainly affected, it leads to secondary Porter syndrome and this huge abdominal enlargement. And this usually, if the main brunt on the kidney, this patient is usually not going to survive long. But if the main brunt on the liver, this patient is going to survive and reach adult life. The other group of diseases, which is again, this is the most common cause of genetic renal failure in children. It's a rare disease, 1 in 100,000. It's called the nephronophthisis. And there is more than 13 genes causing this. And actually, it is presented in childhood with polyuria, polydipsia, short stature, anemia, and bland urine sediment, and slowly progresses to the end stage in the first decades of life. What is peculiar to it? It's extrarenal manifestation, because in main front on the nervous system, retinitis pigmentosa, and the neurological manifestation, sometimes with hepatic fibrosis and the skeletal dysplasia. Another peculiar extrarenal, polydactyly and syndactyly. It's syndromatic. So it is multisystemic syndromatic presentation, but take care, the main front and very peculiar and common to this disease is neurological manifestation and retinitis pigmentosa, liver fibrosis, polydactyly and syndactyly. This is this is retinitis pigmentosa, and this is very peculiar and diagnostic to Joubert syndrome, which is hypoplasia of the vermis, اللي هو molar tooth sign. This is Joubert sign with cerebellar vermis and hypoplasia, which causes this molar sign in MRI. Of course, it's syndromatic, and it depends on the extra-renal manifestation to characterize the syndrome. It is a nephronophthisis with renal cyst, and it is a ciliopathy also. If we go to the congenital, which occurs not due to direct genetic hereditary disease, but some event happened during intrauterine life leads to medullary sponge kidney and cystic dysplasia. This medullary sponge kidney is very small, tiny dilatation of the distal tubules. It's just ectasia. And it is not diagnosed by ultrasound, by the way. It's diagnosed by IVB or CT. It gives this very peculiar brush-like densities here. This is very peculiar, just pooling of the dye inside the ectatic tubules. And it is a benign condition, not transmissible, not hereditary in most of the cases, and some may be present with some stone formation. We discovered accidentally in the patient with recurrent stone formation and some calcification. This is medullary sponge kidney. Of course, the dysplasia, sometimes unilateral dysplasia, sometimes bilateral. And if you find here in the post-mortem, or if you take a biopsy, there is some cartilage formation. It is a hamartomatous, and it is some event happens accidentally in the intrauterine life. This is the medullary cystic dysplastic kidney acquired. And this is very important and actually very common. Simple renal cyst. The incident to find a cyst is like Dr. Ahmed said, it is like gray hair. It will happen, especially after the age of the 40. It's very common. So it is common up to is that 20%, more than 20% of the patient aged more than 70, you will find at least one cyst. And you will find it bilaterally in 10% above 70. And the incidence is increasing. And it is very important to distinguish simple cyst from complicated cysts. This is important. And we put Bosnia classification for this. If you find the cyst is thin-walled, clear content. This is simple. Maybe sita. This is Bosniak 1 and 2. This is benign. And you don't ignore it. Nothing. This is graying of hair and it's an aging process. But if you find some solid masses, soft tissue, and frank soft tissue and complicated, this is definitely malignant. This is highly malignant. This is too benign. 2F and 3 needs careful follow-up. And you have to involve the urologist with you because these two cysts might be malignant or turn malignant. And also we have cystic kidney disease. The patient on dialysis, they develop cyst, and we call it acquired cystic kidney disease. This is the name given, but it's the dialysis associated. And there is some incidence also, small incidence of one of these cysts to turn malignant. So some protocols of the care of the dialysis patients put ultrasound screening annually as a part of the care of the dialysis population. Another rare entry, but you have to keep it in mind, that some acquired forms of cystic kidney disease is associated with hypokalemia, and it is being documented and repeatedly reported in the literature with syndromes with hypokalemia like Conn's syndrome and periodic paralysis, hypokalemic periodic paralysis. And this because potassium is involved in maintenance of the tubular epithelial proliferation and function. And in case of hypokalemia, some proliferation and plugging of the tubules happens with secondary formation in a chronic cases. Some cyst, it starts to form inside the kidney, and this peculiar type is reversible. If you correct hypokalemia, it is reversible. Cyst will disappear. This is another entity, just I would like to draw your attention that it's sometimes associated with hypokalemia. So up till now, I discussed the hereditary, the congenital, and acquired. And on all these entities, we depend on the clinical picture and imaging characteristic of each entity of which is usually diagnosed. But what is the role of the genetics? When I go to genetics, I need genetics to discover. This is just clinical algorithm. This is clinical algorithm to confirm. Yeah, we mostly, in more than 90% of cases, we depend on this clinical algorithm. If you have bilateral disease, normal size, it is not too much enlarged. This is autosomal recessive or autosomal dominant tubulointerstitial disease. This is associated with early onset gout, and this is associated with extrarenal manifestation. If you have enlarged kidney with bilateral cystic kidney, if the liver is affected, this is autosomal recessive polycystic kidney disease. If it is no much liver affection, this is autosomal dominant polycystic kidney disease. But you need sometimes that the picture is not that clear cut, and you cannot reach a diagnosis from clinical and imaging only. Such in cases suspected patient with polycystic kidney disease like without family history. This is the proband, and there is no family history. Suspected autosomal dominant kidney disease with equivocal imaging, atypical imaging. Autosomal dominant polycystic kidney to be excluded in the patient with less, in less than 30 years or 25 years, and he insisted to know if he has the gene or he has no the genes for living donation or for insurance issues, and sometimes for fertilization and pre-implantation genetic diagnosis. Some families, they don't want to have any polycystic kidney disease in their families anymore. They go for IVF, and they select the zygotes which do not have the gene mutation. Sometimes we have to identify patient at risk for disease modifier. As I told you, the genetic of the PKD1 truncated, non-truncated frame shift is in the scoring system of the severe pro-PKD scoring system. So sometimes if you are going to enroll the patient in trial, we have to score this mutation. So we have to identify them. Sometimes we have a dilemma, early and severe disease. This is unusual in the polycystic kidney. The discrepancy between imaging finding and renal function. Asymmetric unilateral segmental loop-sided marked intrafamiliar disease discordance. All of this, we have to go for genetic in a trial to solve, to understand what happened, what is the clinical picture. We have to correlate genetic and the phenotypic abnormalities in this patient. And again, we go to the genetics. Which genetic test you are going to ask for? If you are suspecting single gene, you go for single sequencing or target next generation sequencing. Either you go for one gene or few genes. If you have syndromes and you multiple organ affection, you go for chromosomal study. If you don't know what you are dealing with, sometimes you go for whole exome or whole genome scanning. Nowadays, especially in Europe and in the States, we have a panel, next generation sequencers, allows us to target different genes at the same time, and we can study up to 10 genes or more at one shot. So this is one of the studies, is only including most common genes causing the polycystic phenotype, and it's only for $1,000 in the States in one of the university labs. So it is easy to do now, target next generation sequencing to detect these genes. As I told you, we have different techniques. Each technique has its advantage and disadvantage. This is single sequencing for one gene. Next generation sequencing, different genes. Chromosomal study, if you have syndromatic presentation. Whole genome or whole exome, also you can detect the different genes and the new mutations. This is one study which shows from 800 probands. Proband is the first presented in this family. If you go for targeted genes, most probably you are going to detect this pathological in more than 80% of the population. 90% atypical, you have to go for whole exome, a second step. 60%, 60 from this 800, they are almost 5%. You have to go to whole exome or whole genome, and sometimes you have to go to another step with segregation studies and in-depth study genetically. Why I'm saying this? Because we find patients with autosomal dominant polycystic phenotype, and we didn't find any mutation. This genetic study discovered that there is some variable of undetermined significance. Sometimes we find a mutation, but has never been in the literature to cause any phenotype. So we said this is mutation with undetermined significance. This is variable of undetermined significance. Here comes its significance. When it alone doesn't cause any phenotype, but if the mother and the father, both of them carrying this hypomorphic alleles, one of the probands will be affected with a typical picture of polycystic kidney disease. This is hypomorphic alleles, and it is being repeatedly in the last 5 years solving a problem of polycystic kidney disease with no family history, with no definite transmission in a Mendelian fashion. And another discovery which we discovered that if you have germline mutation, this is the classic picture of autosomal dominant polycystic inheritance. But sometimes it happens somatic mutation, post-fertilization, that the patients will have somatic mutation in the de novo mutation somatically in the polycystic 1 genes. So he has a polycystic phenotype, but this is not transmissible to his offspring. And sometimes we have combined germline and somatic, and also it can be transmitted. So somatic mosaicism, we call somatic mosaicism, is another explanation of atypical presentation of polycystic kidney disease. Why I am saying this? Because as I told you, genetics now is being incorporated in a scoring system for polycystic kidney disease, ProPKD. So we have a clinical characteristic, male, hypertension before the age of the 30. All of these are indicator of severe disease. First urological event, infections, hematuria before the age of the 32. BKD2, it's 0 because it's mild disease. Non-truncating BKD, it is also mild. Truncating BKD mutation is 4, it's severe mutation. Of course, imaging now has a very tremendous progress, and it characterizes these patients, and it can study the tissue of the kidney functionally, which is compressed, how much fibrosis, and Mayo Clinic classifications has been classified patients with typical polycystic kidney disease type 1 into 5 classes, A, B, C, D, E. And of course, with each class, this is the class A and B, it's green, they have a slowly progressive disease, but C, D, and E, it's a very progressive with rapid decline in the GFR, and this is why you have to intervene early. The earlier you intervene, the much benefit you take from, for example, tolvaptan, that it will decrease the slope of decrease or loss of the GFR. And of course, as I told you, I will not go too much into the therapeutics, but nowadays it comes in the focus the nutritional aspects in and the metabolic syndrome in the progression, and we have a lot of other modifiers we can put into consideration to slow down the progress. Up to now, what we have is to slow down the progression and to prolong the survival of the kidney, but we don't have a definitive treatment. Hopefully, with better understanding and characterization, we reach a point that we can better do for our patients. And finally, thank you very much.
Thank you, Professor Hatem, for this very interesting and comprehensive lecture. Professor Ahmed?
Yes, assalamu alaikum wa rahmatullah. Dr. Hatem, really very much interested, very explosive pieces of information. Thanks for the nice gathering and for the updated information. الحقيقة Dr. Hatem, you mentioned many points. Each of them would need a one night for discussion. To sum it up and look for the questions, Professor Hatem mentioned to us the classification of cystic kidney diseases based on whether these are acquired or congenital or hereditary. He very nicely admixtured the autosomal dominant tubulointerstitial kidney disease with a polycystic kidney disease with a compound multi-system affection that contains cystic kidney disease. He mentioned the contagious gene syndrome with the large deletions on the chromosome number 6 for the TSC2 with or TSC2, yes, with the PKD1 that can combine two types of cystic kidney disease altogether. And he very nicely showed the genetic abnormalities in the PKD with the explanation of the mysteries about the propands and the late presenters and the hypomorphic alleles and the genes that can be protective against the occurrence of the cystic kidney disease that can when they are mutant, the appearance of the cystic kidney disease can be increased or amplified. The other types of cystic kidney of gene abnormality, like the DNA G11 and the GANAP and types, the AGL and others that are being, although they are much less than one situation. So it's very, very nice. I know that for non-specialized in the PKD and in the genetic, there would be a lot of information, but I advise you all to rehear or go through the presentation more than one time. There are pearls in this presentation that will go through the questions. No cyst formation be prevented before it occurs if the causative gene is known. So I think this is from Muhammad Hassan. He's implying to the gene therapy whether we can target prevention of cyst formation early on in life. Professor Hatem, you've elegantly as well showed the role of BGD and pre-implantation genetic diagnosis that can help prevent having a disease. But is there a potential role for any genetic intervention to prevent the appearance of the cysts?
Before that, we don't have genetic treatment for the polycystic kidney. For example, PKD1 is a huge gene. الو انا صوتي مسموع؟
اتفضل يا حاج.
البوليسيستيك كدني PKD1, which is the most common, it's a huge gene, 46 exon. You cannot imagine. You cannot do this. Actually, it's a dream to reach a genetic treatment. But genetic treatment, again, when I first time heard about genetic treatment, I was in France at the time, and it was a very big event that they treated genetically severe combined immunodeficiency syndrome. They treated 10 patients with genes. You know how to do gene therapy, how to introduce the genes which is, of course, for hematological diseases, it is very easy because the tissue is accessible. I can take the progenitors and the bone marrow biopsy, and I can deal with this in vitro and deliver the genes to the cells. You know, by the end, they did this for 10 patients. By the end of 1 year, 7 patients went to leukemia, 3 patients relapsed. So gene therapy is really serious. You are dealing with the genes of the patient. You don't know how to implement the gene in the correct place. You induce some genetic changes if you do this. So we dream about gene therapy, but actually it is still far away, still very difficult. And we don't have it for polycystic, by the way.
Thank you, Hatem.
Okay, thanks, Professor Hatem, for the point. Is applicable in some other diseases, and gene therapy is a vast beyond editing genes, but for PKD it's still very difficult. Nowadays, we know that there is the siRNAs or the short interference RNAs, which are already in the market for the inclisiran, for example, for the dyslipidemia, lomiziran for the PH1 or the primary hyperoxaluria, and patiziran and others. And there is a CRISPR gene editing now by editing genes to try to change the protein output of the gene. And there are some other modalities with interference with the genes, but definitely, as Professor Hatem highlighted, this is not by any means is directed toward the PKD, and the gene is huge gene, and the mutation is actually it's not a simple mutation in one gene. There is a multiple and multitude of variants in even in each for tolvaptan indication and target blood pressure.
Tolvaptan, you'd like me to answer?
Yes, please.
Yes, please, Professor Hatem.
Tolvaptan is a useful tool, but you have to employ it to the patient with rapid progression, as defined by the guidelines now. And there is a guidelines recently published by Kidugi in 2025 for treatment of polycystic kidney, autosomal polycystic kidney disease. Of course, you have to identify the rapid progression. Rapid progression, this entity, more than 6 in pro PKD, if he has a score of more than 6, or in the Mayo Clinic imaging classifications beyond stage A or B, C or D, of course. And if you employ it very early, if you employ it when the patient, his GFR is more than 70, you delay, as I told you, you do not prevent the renal failure, but you delay the reaching end stage by 7.5 years. You buy 7.5-year renal survival. And if you started late when the GFR reaching around 30, you just 2.5 years. So it depends. You have to start it with rapid progression because not all phenotypes, you have, as I told, different mutation. If you, for a patient with less progression, you might not have the same benefit with rapid progression. With patients with rapid progression, of course, they will benefit from tolvaptan, pro PKD score more than 6, or Mayo Clinic classification, imaging classifications beyond A and B, type 1. So when you employ it very early with GFR is still normal, above more normal 70, you get 7-8 years renal survival more. If you in 30, you are only buying 2.5 years only to delay the progression.
Let me ask a question,
Okay,
Mr. Ahmed. Hatem, in the view of side effects
تفضل
known,
تفضل.
in the view of side effect profile of tolvaptan, and in the view risk-benefit ratio, side effects known for side effects of sodium affection and liver affection, of course, and risk-benefit ratio, what's your opinion regarding this point? Does it worth and or the conservative treatment in the form of plenty of water intake and dietary therapy can compensate somewhat for this entity?
I didn't use tolvaptan myself, but according to the guidelines, no, it's beneficial, cost benefit and risk. Yes, for the rapid progressors, it's beneficial. For the patients, you followed them up and you know that their kidney function and is maintained. GFR is not more declined more than 4 ml per kg per year, 4 ml per year. And the increase in volume is not that much. And he might have a benign mutation and he might not benefit. This is why, because of these side effects you mentioned, Dr. Yasser, they didn't apply it for all the patients. They didn't say use it for all polycystic kidney disease patients. You have to identify the high-risk patients. Pro-BKD more than 6, because this patient is, if you buy 7, 8 years, is good. It works, but you have to keep an eye on the patient. So you have to introduce it very slowly. You have to keep an eye on the liver function every 2 weeks for almost 1 month, then every month for 1 year. Then you have to follow it up for 2 years, almost 1.5, 2 years, keeping an eye on the liver function. Of course, of sodium, because you have to keep the patient. This patient is obliged to drink 3 to 7 years per 7 liters water per day, and not all patients tolerate this. You have to maintain normal sodium. This patient has to drink from 3 to 7 liters per day with too much polyuria, not even in his work, and it might interfere with his quality of life. We put patient adherence to the treatment in the natural course of the disease. Not all patients accept this.
It is what I am speaking about. Mr. Ahmed, please, we have some questions about biopsy and proteinuria.
Yes. Yes. Just a final comment about the management of PKD. We know that the HOLT A and HOLT B trials with blood pressure reduction down to 120/80 and even maybe less, and using ACE inhibitor with no added value of combination of ACE and DRBs, with some other recent trials of ketosis to use the Marburg effect in decreasing the cyst size, and the plenty of water, as Professor Yasser mentioned, although it did not show actually a positive result, and maybe the intermittent fasting as well. All these have been tried for a long time, and they showed equivocal results, not very strong signals. On the other hand, the mTOR inhibitor had failed already in improving the outcome, and many others had improved. But tolvaptan is already in the guidelines. So yes, we can use it with the criteria that Professor Tariq mentioned very strongly, and we can just stick to the close monitoring of the liver function. If they are tripled or more, we can stop it. Sodium level, the division of the dose into 2/3 in the morning and 1/3 at the night. All of this is really important to manage those patients. We cannot neglect the effect of tolvaptan when it's on the guideline. Now, in patient with ADTKD and acquired cysts, how do we differentiate between autosomal dominant tubulointerstitial kidney disease and acquired cysts in patient on dialysis? Please, Professor Hatem just mentioned. What's your comment on the question?
البيشنت اللي عند dialysis ما عندوش same picture, clinical picture بتاع tubular interstitial. As I mentioned, these patients has some peculiar early onset gout, for example. Some of the patients have some hypoproliferative bone marrow and anemia. Some have some concentration problems. So you have problems in the interstitium, denoting that the interstitium is the main front of the disease, early onset. So this patient has chronic kidney disease from, this is autosomal dominant tubulointerstitial disease group of patients. They have bland urine sediment, they have early onset gout, they have problem in the concentration of urine, they have peculiar picture. But the patients with acquired cystic kidney disease, dialysis related, he has small atrophic kidneys, not normal sized kidneys like tubulointerstitial, this is normal sized kidneys. The other one, autosomal acquired cystic kidney disease with dialysis, this is atrophic kidneys with a small cyst, and he has different clinical picture backwards.
Okay. Again, the localization of the cyst, Professor Hatem, I think with ADTKD, the cysts are smaller in size and they are in the interstitial compartment, the medullary, more than the cortical cysts that is placed in the dialysis. Yes. Another question is how to manage heavy proteinuria in patients with autosomal dominant polycystic kidney disease. since biopsy cannot be done. I really object for the question, but what's your answer, Professor Hatem?
I confronted with this one case in my life, but it was not in Egypt. And they take a biopsy from the patient, and they found that he has a primary glomerulonephritis. But they take the biopsy, interventional radiology, retrograde, we take
The tips from the jugular vein, from the jugular.
Yes, they have transjugular. They take it like this. Because if you take the biopsy from these kidneys, you might have complications.
Yes.
And this is published in the literature, and the patient has a glomerulonephritis. Usually, the patient with polycystic kidney disease have not heavy proteinuria like this. Usually, you don't confront it with that. He has proteinuria and it has a prognostic factor. But usually, it is not heavy. If it is heavy, he might have some other primary glomerulonephritis coincidentally with these patients. They are part of the general population. They might have primary. But taking a biopsy in hugely enlarged polycystic kidney like this is hazardous. You cannot take it. It's very difficult.
Yes, but sometimes it's not that usually enlarged. Actually,
if you manage and
I've done it once in my life with a patient with heavy proteinuria, and the PKD, it was only 23 years, I remember, and we managed to take a biopsy, just percutaneous biopsy as usual, very ultrasound, definitely real-time ultrasound to be guided to be away from the cyst, and the patient was found to be FSGS associated with the polycystic kidney disease. Definitely, it's not applicable.
Yes.
The transcutaneous biopsy, Professor Ahmed, I think it's so difficult. Internal jugular.
It's definitely it's not applicable to patients with multiple, numerous, or huge big cysts. But sometimes in the early, as you might know from the Rabin criteria, in the 20s and 30s, you might have only 2 or 4 or 5 cysts in each kidney. Likewise, when you have a cystic kidney disease, simple cysts, for example, this does not preclude the biopsy early on. Yes. He was 23 years old. That's why we managed to do it. Okay. All patients with ADPKD reach end stage? The short answer is no. Professor Hatem showed elegantly that PKD1 does not progress. PKD2 does not progress as much as PKD1, and not all of them definitely reach end stage. There is a question: any evidence to use GLB1 agonist for weight loss in autosomal dominant polycystic kidney disease? What's your take, Professor Hatem?
It can be used like any part of any person in the general population, but for particular interference with the course of the polycystic kidney disease, I am not aware it will make any benefit to the patient.
He's just asking about the weight loss. About the weight loss, whether we can use
it. For chronic kidney disease, what applies to the chronic kidney disease patients applies to polycystic kidney disease patients. So in the care also. So weight loss, of course, it will benefit chronic kidney disease patients, and autosomal dominant polycystic kidney disease is one of them.
I have a question here about continuing for this question. And SGLT2 inhibitors, Hatem?
No recommendations. No recommendations to be used. It doesn't give any benefit up till now, and it is not recommended. Even it may be worse because it will cause too much polyuria and contraction of the intravascular volume with increasing vasopressin. So it is maybe deleterious. It might be not suitable for polycystic kidney patients.
If I would like to have an opponent opinion, I've asked previously the Canadian guy is Cherry, yes, Cherry, and in a meeting together, and he said that although they were, there's no point of thinking that they wouldn't help. They might be promising, they have not been established, but it can be tried. And he said very clearly that the exclusion was because of the fear of the side effects, like they excluded the immunosuppressed patient and the transplanted patient for the fear of the UTI and the occurrence of infection in the cysts and so on and so forth. But it could be helpful with what's going on nowadays, with the more confidence in the drug. So we're waiting to find whether it can help or not. It's not the final verdict yet.
Studies are, I think, under study now for in the disease, it's LGT2 بالذات.
Yes. There is another question of any cutoff number for simple cyst diagnosis. I mean, if you find like 10 cysts, can you say, no, this is not a simple cyst?
Unlikely to be that much. It's usually 3, 4, 5, 6 sometimes, but 10 is too much. I didn't see this 10, but it is, if the patient is 80 and his kidney function is normal, of course, I will just consider it, and he has no family history. Of course, I will consider it like this, but usually this is unlikely.
Okay.
Again, can I continue the question by another one? And the size of the cyst, is it important? I had one patient having a simple cyst, clearly stated that it is a simple cyst, but it was very huge, nearly approaching the kidney size. Is it suspicious, or we go through it as a simple cyst as usual?
You have to go to Bosniak classification. If it is thin-walled, no contents, clear contents, of course, no, there is no size particular for simple cyst. Yes, it might be for huge, but when it's large like this, sometimes it will cause some complication like spontaneous rupture, infection, pain. It's more liable to cause. And at that time, sometimes we intervene radiologically if it is symptomatic. But if it doesn't cause anything, of course, it is simple, and it is fit into the Bosniak type 1. It's okay. It's simple. No, regardless of the size.
Yes. Okay. We used to have what we called Rosvik technique with the cyst aspiration that is condemned more or less now. But if you have a peripheral polar, mainly lower polar cyst that is more than 7 centimeters in diameter, it might be advisable that you would do cyst aspiration, but usually it will recur again. And in this
you have to inject. You have to inject some.
You can do laparoscopic marsupialization of the cyst.
Yes, of course,
and just
penetration. Yes.
This cyst was about 11.
Yes.
It was about 11 to 12 centimeters and was upper polar.
Upper polar is difficult to be aspirated, but can be removed by a laparoscopy. Okay, there's a question about the ACE inhibitor in treatment of hypertension in those patients. Is it the drug of choice?
Yes. Yes, because it has some also benefit molecularly. It decreases the fibrosis, decreases the ischemia, because how the cyst, this is very interesting. How in autosomal dominant polycystic kidney disease, and we know that each kidney contains 1 million nephron. And only the cystic changes occurs in less than 100%, in 1% of this. How this 1% leads to renal failure? The renal failure occurs because the cyst compresses the other renal tissue, normal renal tissue, causing ischemia and interstitial nephritis. This is why ACE inhibitors comes into play, because it has some pleiotropic effect and anti-ischemic measures. It delays the secondary events which occurs due to cyst enlargement. So ACE inhibitors, RAS blockers is in the top of the list and the drug of choice for treatment of hypertension, and it is also mentioned in the guidelines 2025.
More questions,
yes,
Professor?
Thank you. And again, okay, to Yassir, just a final comment reminding of the HOLT A and HOLT B studies. The HOLT A was concerning with the target blood pressure, and the lower the better in PKD, and the HOLT B studies showed that you cannot add ACE to ARBs again, likewise in the other trials, but definitely it is the drug of choice in managing those patients.
We have a comment from Dr. Ahmed Amara.
Dr. Yes.
Dr. Ahmed Amara, تفضل.
Assalamu alaikum. Thank you, Dr. Hatem, for this very nice lecture. I have a comment and a question. A comment regarding the case of a patient with cystic kidney disease and proteinuria. As I have seen this profile recently, and was diagnosed to have primary membranous nephropathy by serum antipleural, so we can rely on it to diagnose such a patient who not fit for biopsy. A question regarding, I think you mentioned the entity of ADB-LD, autosomal dominant cystic liver disease. As also I have seen 2 cases recently with predominantly liver cyst with bilateral renal cyst, but not so large. But the problem was the liver cyst was growing and enlarging and necessitating resection of this cyst surgically. I'm not sure if there is any role for tolvaptan in these cases, or any kind of treatment for mainly liver cyst with also kidney cyst. Yeah.
Somatostatin is indicated and in the guidelines. Somatostatin is very beneficial, not tolvaptan. Somatostatin is for liver cyst, and it is in the guideline.
But I think we have to do genetics for these patients to make sure, or
yes. If it is solely, it's only liver. Yes, there is some other genes which cause polycystic liver disease.
It's a liver and the kidney, not only liver. They have liver and the kidney, but the problem mainly in the liver cyst. It is rapidly growing and
in the context of dominant polycystic kidney disease, liver cyst is more in the woman, especially multiparous, because estrogen plays a role. And if he is from a family, if the family known to be polycystic only, and if family history clinically shows that it's polycystic, and this polycystic liver is a part of autosomal dominant polycystic kidney disease, it's okay. Khalas, this is autosomal dominant polycystic kidney disease. But if it is mainly polycystic liver only, and the kidney, this is genetics, you have to distinguish it. Like, of course, polycystic liver is part of autosomal dominant polycystic kidney disease, especially in females. This is why we usually instruct female patients with polycystic kidney disease not to have 2 more children and don't use contraceptive pills using estrogen, because it will increase the incidence of liver cyst. And in the treatment, is somatostatin is indicated, and sometimes it is too much and huge, and finally you have to do combined liver and kidney transplantation.
Okay.
I think in the TEMPO studies, the regression in the liver cyst was insignificant clinically. If I remember well,
somatostatin do better. Somatostatin do better.
Non-statistical significance. Yes, I think yes. Maybe yes, somatostatin can help more effective in liver cysts. Yes.
Thank you, Professor Ahmed. We reached to the end. No more questions and no more comments. So please close.
Okay, thank you.
Thank you very much.
Very nice, very interesting.
شكرا جزيلا للمشاركة والتعليقات. الله يخليك.
Illuminating, very updated. جزاكم الله خيرا وعلم غزير ينتفع به إن شاء الله. Really, I advise to hear the lecture again and again يعني. جزاكم الله خير.
شكرا جزيلا.
جزاكم على خير إن شاء الله.
Hatem for this very interesting lecture illustrating all these simplified points regarding cystic kidney disease. And thank you, Professor Ahmed, joining us with your great experience in this field, especially in the genetic part of the field. And thank you for all audiences for their share, comments, and enriching this heavy scientific discussion. Thank you, and excuse me to close. صباحو على خير. السلام عليكم ورحمة الله وبركاته.
وانت من أهل.
عليكم
السلام ورحمة الله وبركاته.
I am to thank Dr. Islam Abu Ni'ma, our coordinator today, the lecturer of medicine and nephrology in Cairo University, and one of the very active CME chapter members. Thank you so much, Dr. Islam, and thank you, and صباح الخير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله.